sad story. I'm shot in the chest and I know I must die.
So in the meantime, I thought that Joe and I, on behalf of the Alzheimer's Association and the Geriatric Education Center, we want to say thank you very much to all of the volunteers who planned this conference. There is absolutely no way that we could do this kind of thing without all of the volunteers and the time and the hours and the dedication. So we wholeheartedly want to recognize and thank our volunteers, starting with Ms. Judy Luzon. Thank you. She really was our point contact person here in Laredo, and just anytime we needed anything, we could just email or call, and we cannot thank you enough. Melissa Guerra. Yes, thank you. And Melissa, by the way, is co-facilitates our local support group here in Laredo. So make sure and pounce on her for information if you don't already have the information for the local support group here in Laredo. Esther Fuentes. Thank you so much, Esther. Esther was our main contact person for the symposium that we recently did in McAllen, and just was incredibly helpful. And Vicki Flores, who stepped in also. Thank you so much. And then we do have one for Iris and Albert from the AAA to just say thanks for their support and being on the planning calls with us. And just again, we want to say thank you so much to volunteers. There's no way that we could coordinate these types of events without your support. Our next one coming up will be in Corpus Christi. And so we've got several more coming up after that. One more thing I wanted to just let you guys know about and also ask for your support on while we're waiting for Dr. Gonzalez is advocacy. I know that Belinda talked today about the programs and services of the Alzheimer's Association, how our mission is to eliminate the disease, so we raise money to fund Alzheimer's research. The other part of what we do is advocacy, and that is to take action to let our elected officials know, whether at a state level or the federal level, that there's so much more attention that needs to be paid to Alzheimer's disease. The grant that funded this, that came through the first ever National Alzheimer's Plan, that was a major advocacy success. That was huge. But we continue to need more. Now that the plan is in place, there has to be funding to be able to fund all of the objectives that the plan outlines, including coming up with a cure for Alzheimer's. So I put on everyone's desk table an advocacy card, and even if you just recently filled one of these out, we would greatly appreciate if you would put your information on here. This does not go into our donor database. That's a different one if you make a donation. This one is our advocacy database, and basically we send this postcard to your elected official, whichever zip code you are in and what you represent. And basically it gives them the statistics of the amount of people who are affected with Alzheimer's disease. And basically what you are in essence saying is that, okay, we want to ensure the implementation of a strong national Alzheimer's plan, but they need to make Alzheimer's research a priority at the National Institute of Health and to sponsor legislation that will ensure diagnosis and care planning. So that third bullet point is what we call the Hope for Alzheimer's Act. And then last but not least, your leadership is needed now more than ever, that Alzheimer's can't wait. The disproportionate amount of funding that comes from the federal government towards other diseases is actually something that has helped decrease death rates for individuals who have cancer and who have diabetes and who have heart disease. Of the top 10 killers in America, Alzheimer's disease is the only one that does not have a treatment to prevent it from progressing. It doesn't have a way to prevent it, and it also has no cure. It's the only one in the top 10. So more than ever, we need people to, we feel like you already are advocates, but we'd love for you to make it official and fill out a postcard, leave that with us, we'll send it in, and then there's a sticker, and if you'll wear that today, we greatly appreciate it. It says, "One voice against Alzheimer's." And that's what we need. We really appreciate your everything, you spending the day with us, and I will turn it over to Esther, who is going to introduce Dr. Gonzalez. Thank you.
Dr. Gonzalez, thank you for being here and taking some time for this schedule. Dr. Gonzalez is currently an associate professor at the University of Texas Pan American in the Department of Social Work. His research interests are in aging, delivery of mental health services to older minorities, and culturally competent practices. So I will turn it over to Dr. Gonzalez. Thank you so much.
Well, good afternoon. You all hear me okay? What y'all do with everybody else? Good. I'll confess to you, I have a stand-up comedy personality disorder. I think I'm funny. Unfortunately, my diagnosis did not make me DSM-5, but I'm still working hard on it. I'm here to talk to you guys about ethics and service delivery and diversity, so we'll go through a few different things this afternoon. One of the things as we go along, if you do have a question, please raise your hand. Because normally I like having an exchange as opposed to me just talking and talking and talking. So you're welcome to ask a question as we go along. Let's see, what else? I was over at the NASW meeting earlier. That's where I came from. Sorry for being a bit late. Let me just... I got a clicker, I'm sorry. Okay, so to begin, when we look at our country and we look at Eaton, Texas, we're pretty diverse now, aren't we? We look at culturally, ethnically, we look at demographic trends. There's what I think Hispanics are the #1 minority, and at some point pretty soon Hispanics in Texas will not be the minority, if not very close. Either way, though, there's a lot of diversity within our culture. When you consider Hispanics, we're not just Mexican Americans. We're Puerto Ricans, or Cubans, or Nicaraguans, or El Salvadorians, or Hondurans. So it's important for us to understand that. And that's just Hispanics. That's not to mention other immigrants that might be coming to our communities. So with that, it's important that we communicate effectively with patients. That we understand them, and that they understand us. Okay? If they don't understand us, then are we doing pretty good services? Probably not. Okay? Now, before I continue, I do want to just kind of survey it right quick. Let's see. let's by profession, do we have, how many people work in social services? Okay. Let's see, how many people are nurses? Okay. And let's see, so apparently there's other helping professions in here that are used in one answer. Must be a long day. It's okay, I wouldn't trust me either. So then what am I missing?
Family.
Okay, families? Oh, well, how many family members are here? Oh, excellent. Okay. One of the more important things to not just family but to the professionals is, as professionals, who is our client? Is it that one person that we're talking to that comes to our office? No, it's not just the person that comes to our office, but it's the person that brings them. And it's the person that takes care of them. And that's really important. That's something that as professionals, we have to take into account. That's still part of all this whole communication part. Okay? We really have to look at that. Now here's the definition of pathways. Pathways being how our clients get to us, how clients get to the services that they need. Okay? So one definition, this is an older definition, is the sequence of contacts with individuals and organizations prompted by a distressed person's efforts and those of his or her significant others, their family, to seek help as well as the help that is supplied in response to such efforts. Now, in this definition, it says a sequence of contacts. So it's not really, is there one way of getting help? No. There's a variety of ways. So this definition is individual for any patient and family. How the contacts that they use and the contacts that they access are going to make a difference. But they're also, ultimately, hopefully they get to what they need. And it just may be, and at the same time, us as professionals, we have a role in helping them get to what they need. And again, this brings us back to communication and making sure that we're understanding what they need and they're understanding from us what's going to help them. Okay? So now, in order for professionals, in order for ethnic minorities to walk through a door for treatment, it's important that the services are accessible and acceptable. So consider being a caregiver, a family member. Well, you want to be able to get to where the place is, where the service is. But you also want to understand what the service is about. And you want to make sure that you understand it. So that way you accept it. So if the service is, if for family members, when it's a new service to them, and they've never been to that agency or needed that help, the very first contact they're going to have, for the most part, they probably don't want to be there, because what are family members dealing with, particularly with Alzheimer's? Family members are dealing with normally an aging parent that is having their own issues, and who wants to see their parent in this state? So who knows what's going on with the family caregiver? So in getting to, not just being able to get to where the place is, but then understanding what's going to be done. What are you going to do to my mom or dad? How long is this going to take? What do you need from us to get them here, if it's every week or whatever it is? How long is it so that transportation be arranged? So that other child care arrangement can also be arranged depending on the grandchildren and the children of those caregivers and what they need. So all that stuff is really, really important to keep in mind. Now, again, as we go along, if I miss something, shout it out so we can add it to our presentation. So I think that's really important. When I teach my classes, I always tell my students that to ask questions, and that there's no stupid question. Okay? The only stupid question is one you didn't ask. What we don't know is that there might be information I could get, possibly from me, but possibly from somebody else in the audience. And that's also really, really important. Now, in our country, as far as with healthcare, with the racial minorities, there's been a lot of barriers. A lot of economic barriers, administrative, communication, again, is something that we talked about at the beginning. That's been a barrier, which would include language. Maybe not the best information. Maybe we don't have enough education out there for caregivers to understand what is offered and how it can help. Historically, with the some ethnic minorities, there's a distrust of the delivery of services. When we consider mental health, that would include stigma. Okay? My mom or dad's not crazy. They're okay. And then they talk about the same thing again. No, they're fine. I was watching a cop show the other night. And it was what's really, on some of the TV shows that I'll watch, not reality shows, they're starting to throw in a character that's dealing with caregiving. And this one cop show that I was watching called Golden Boy, one of the officer's father shows up because he's on the highway. And he's looking at telling his son that he's designing a new system thing. So he tells him his new idea. Of course, the son kind of has an idea of maybe something's going on with Dad, but at the same time he's saying, Dad's sharp. Dad's still got it. Then they go to dinner at his sister's house, which is where the father lives, and they're going back and forth, and he's telling his sister, no, he's sharp, he's good. So then after dinner, he goes to talk to his dad, and his dad tells him, have I told you my latest idea? Which he had told him earlier in the show. It's about these things, and he just repeated the whole idea. And the cool thing was, in watching the scene play out, the actor did a really good job of getting it. That is different. That has changed. And it's part of it is stigma. Part of it might be denial. Those are more, I would call those more personal barriers as opposed to what we're looking at up here on the slide. That would be, more structural barriers. But even then, in getting through these things, if I don't have the education and understanding what the information is that I need to know to take care of my parent, then I'm going to be at a deficit. Okay? So a lot of it sometimes will come down to really the language that might be used and a lack of, again, appropriate information. There might be a brochure that might be translated into whatever language. But if we translate something from English to Spanish, does that guarantee it's going to mean the same thing that it does in English? A lot of times it may not. So in translating something from say Spanish, in this case, we want to make sure that what Spanish words that we use are the same concepts that are in English. You can translate something, but that doesn't mean it translates verbatim. Conceptually, you might lose a lot of meaning, and what does that do? Okay? It doesn't give, again, it doesn't give the right education. Okay? And what it may not do is help with any sort of denial or stigma that families are dealing with. Okay? Which again are not something that is easy to deal with. So now culture was something that was on our list there, and I didn't talk about it because I was going to talk about culture here for a bit. Hang on. Okay. So now with culture, we have several definitions of culture. Let's see. Beginning 99, not in the beginning, but in 99, there's one definition that came from the Surgeon General's report. In 1999, the Surgeon General at the time put together a really big book. And it was a report on mental health. And it had tons of all information that's still valid today. Now, in this report, they define culture as broadly defined as common heritage or set of beliefs, norms, and values. A year later, the Office of Minority Health defined culture as integrated patterns of human behavior that include language, thoughts, communications, actions, customs, beliefs, values, and institutions of racial, ethnic, religious, or social groups. So that gave it a lot more definition. And then when we look at NASW, what they did later on that year is added basically to that definition that culture is often referred to as a totality of ways being passed on from generation to generation. So that culture wasn't only all of these things that are the patterns, but that it's passed on. So when we look at an individual and understanding them, there's a lot to understand about them that we would want to consider. Now, in education, we might have gone through different courses that talk about certain ethnic minorities, or we might watch programs about certain ethnic minorities. And does that mean that we know everything about that culture? We have maybe a framework, but does that mean that the individual that we're going to meet or work with is just like that? Yeah, and the answer would be no. And we'll talk a little bit more about that as we go along. Now, culture is the means by which we receive, organize, rationalize, and understand our particular experiences in the world. We experience something, in this case, mental illness. How we receive. How do we cope? What do we do with it? Okay, all right, say we consider that. What did our parents do with it? What did our communities do with mental illness? How did they receive it or organize it or rationalize it or understand mental illness? Because that's part of how I may understand it right now, until I get more education. Does that make sense? Right? I might have a certain way of understanding mental illness up until a point where I get more education, to then maybe learn more or understand that certain thoughts and beliefs that I have about mental illness in particular could maybe be challenged or just improved. Okay? So now culture is more than language or shared ethnicity. It's also shared values, expressions, thoughts, beliefs, meanings, and traditions. Beliefs, meanings, and traditions are some things that we heard in other earlier definitions. But to me, I think those are really, really important when we consider the families that we're going to work with. And at the same time, for family members to understand where your own ideas come from. Okay? And that's going to make sense here in a little bit. So now, culture sets the stage for how and what we believe and how we behave, solve problems, and communicate. And it influences the way we experience mental illness. Okay? All the things that are part of our culture that are part of us, it'll influence how we experience mental illness, depending on what was in that. Now, I'm going to share with you a model, and then we'll kind of see a graphic that kind of helps maybe understand this model a little bit more. But what Arthur Kleinman did, this is back in 1980, he went and studied mental illness in China, and did this cross-cultural study. And what he found, and what he talked about was explanatory models. How do you explain your illness? Not necessarily mental illness, but illness. When you get sick, how do you explain it? And what do you do with it? Let's say you get a cold, or you get some sort of virus. What do? Do you go to the doctor? Some people might go to the doctor. Some people might say to each other, well, you know, so-and-so had that, and this is what they took. So then they go across and look at that medication. It's still coping with it, okay? But how a person experiences it is one, how they explain it is important to understand. With that, there's also an explanatory model for the professionals. The professionals will get their explanatory models from the school, from the education that they go through. Okay? So now we have two explanatory models. We have the client model, and we have the practitioner model. Okay? So in helping a person, what our jobs are as professionals is to listen to their model and negotiate with them to see how our model compares to their model to help them learn and improve their model. Not to say it's wrong, you're doing it, you don't understand this, but to help understand how you can fill gaps in that they might have. What kind of education they might need. What kind of things that they've been working on and other coping skills that can be better. Does that make sense? Okay. So now, now these models come from like popular stuff. It might come from our social network. I just talked about basically social network. How does the community deal with it? What do people do? Well, they experience this. This is what they did, so I'll do that. If the family did it this way, well, then I'll do that. But again, that's what I learned. Okay, and part of that goes back to culture, but also that all feeds into the experimental model. I might have seen something on television. So I learned from there. Now with the practitioner, again, they're learning from their education and their experience, which is it's professional, and what's on practitioners now is to again help the clients understand where the discrepancies are in the client's model, to help them get better, to help them deal with their illness better. And in the case of Alzheimer's, it's not just helping that individual, but again helping the family understand and cope with what's going on with mom or dad, particularly as they progress. You know, and as they progress, it's not fun. Okay. Now, what Green did. Sorry about that. What I forgot is what I had okay. Up here, what Green did is he talked about the client culture and the professional subculture. Now, within these two cultures, again, it's just like the explanatory model we just talked about. Okay? So, taking the client explanatory model and calling it client culture, and taking the practitioner model and calling it the professional subculture. So, and I just said where those come from. Now, what would be on a graphic would be how we label and diagnose ourselves, how we problem solve, how we get to utilizing services, and how we resolve problems as far as clients. So we would give our illness a name, then we would understand what are some things that we can do about it. We would try those different things that we talked about. I might go to my neighbors, I might go to family members, I might go to the doctor, get a prescription, but then go across and get it from a cheaper pharmacy. I might, either way, I'm getting to solving the problem. Now, one of the things that's important in this model that I apologize for not having the graphic is within this model, there's, between both cultures, there's a box that's called minority professionals. Now, minority professionals are those that basically operate in two cultures. They operate in the professional culture, but they also operate in the client culture. Does that make sense? So what they're able to do is hopefully help translate not just words, but to help clients understand, again, those discrepancies that I talked about earlier, that maybe are missing out of their out of the client's explanatory model. Okay? All right.
So now, with that framework in mind, I have these nice transition slides. So that way you know what goes next. So if you didn't think what I just talked about was boring, just wait. Now, with ethics and values, values are concerned with what is good or desirable. Now, ethics are concerned with what is right and correct. Those are two very important words to understand, particularly service delivery, and just working in the health profession. The hope would be that eventually our values, we'll talk more about this, would reflect our ethics. Now, with professional values, are the values proclaimed by our professional groups such as social workers or nurses. And for social work, the ethics are based on fundamental values that include worth, dignity, uniqueness of all persons, as well as the rights and opportunities of others. Now, if we looked at nursing value, ethics, or values, or even medical doctors' values, there would be a lot of similarities. Okay, so it's all about the person, and it's all about doing right and not doing harm, and we'll look at that. Now, with social work values, our mission is rooted in service, social justice. We want everybody to have an equal chance, in this case, to get health care, to be able to get the right treatments. We value the dignity and worth of the person. Not just the client that might have an Alzheimer's diagnosis, but also the family. We can't forget the family. The importance of human relationships. That I could probably do a whole workshop on human relationships. But don't worry, I know we're out here at 7, right? See, I got 3 things. Okay. 4. Integrity, another value, and competence. One of the things that social work is moving to evaluating competencies as far as education goes, and nursing has been doing that for a while. So we want to have people that are helping those that need help be competent in what their job is. Now, personal values. These are the values held by us, or by you, but they're not necessarily held by everybody else. You have your own individual personal values. Okay? Nobody's doesn't say that they're wrong or right, they're your values. Okay? One of the things I teach, before we get to that, one of the things I try to teach students is the better their personal values are aligned with the professional values of social work, the better they're going to be able to work with ethical dilemmas in their work. Okay, it's it's one thing I can have certain personal values, but then as I become a helping professional, there's other values that I have to follow. So if those are kind of far apart, I probably have internal dilemmas. Okay, so the closer they can get together, not that they have to be totally perfect, but the closer they are to each other, the better for me when I do my job. If that makes sense. Now, ethics, again, are what people consider right and wrong. They're standards that direct one's conduct. They're values and actions, a definition that I learned about a while back. And their behavioral expectations or preferences or responsibilities. And one of the things about the second definition, standards that direct one's conduct. In social work, we have our book, our code of ethics. And again, in all professions, there's a code of ethics in all of the professions. And that tells us how we do our job. What we're not supposed to do, and it tells us a lot of what we're not supposed to do, and also what we can do. Okay, there's certain things that maybe we're not supposed to do. And one of the things that we're not supposed to do is, and this may be too early for the example. I'll come back to that example. So now with professional ethics, these are guidelines that outline our professional standards of practice and behavior. So now they're codes, but the codes don't make decisions for us. Okay? They're just stuff we follow. We still have to make our own decisions. Now, for professionals that might be going to do a home visit, when you sit down with a family or an older person and they offer you coffee, do you take the coffee? Okay, tell me a reason why it's important to take the coffee. I would agree with you. Ethically, we're not supposed to take anything, right? But if I don't take that coffee from that older person, they're not going to talk to me. Then I can't do the best job that I can to help them. Because all of a sudden, particularly if that's part of their culture. True, it may not be part of professional culture. And that's not to say that you take every ethical code and make it work into your favor. There are certain things that can maybe take a cup of coffee, but not necessarily drink it. They might offer you fun. Okay, well, you might take a bite or two, and that's fine. But in refusing that, how are they going to take it? All of a sudden, how much communication am I going to have? How are you today? I'm fine. As opposed to, well, this is hurting me, this is going on, different things like that. And that's, again, that's something that I consider on a case-by-case basis. When I did my dissertation, I went to interview older Mexican Americans, normally in their place where they live. A couple times, they offered me coffee. Now, if I say no to that, there goes my interview. Then my interview probably will be 15 minutes. And I'm going to get two-sentence answers to each of my questions. And they're not going to tell me their story. And I'm interested in their story to learn more about what's going on with them. So that was one of those decisions that I had to make. Even when I worked as a mental health practitioner with older adults and doing an initial assessment with going to their place. Sometimes that happens. Well, if I don't do that, then I offend them. And then all of a sudden, the reason that the doctor referred them to us, that to them, oh no, I'm fine, I'm better now. I don't need to go to the doctor. So we must interpret and apply what goes to their decision making. We kind of switch to that. Okay. So now some common elements of lots of different codes of ethics are respecting and safeguarding the autonomy of clients, respecting their rights, views, and practices of other professionals. When I work on a multidisciplinary team, that's very important to understand that part. If I don't, I can have a hard time working on that team. When I worked at an outpatient geriatric psych unit, of course our big boss was a psychiatrist. Okay? But she was the leader. So now, when she was wrong, did I tell her she was wrong? No. But what I learned is, how would she listen to me? What were the things how could I get her to listen to me? Just to hear my point. Not that I was going to be right. It was more about making a point to help our client. So what I learned to do is speak in her language. And that worked. What it did was help us as a team help our clients. And that's one of those things that's also important to do. So now, these are some ethical principles that we would deal with in working with clients. The protection of life, equality and equality and inequality, autonomy and freedom, We want our clients to be as autonomous as they can be and have that freedom. So when we look at dealing with Alzheimer's, there might be limits to that. Okay, it's understanding that part, but also helping the family understand that part too. The principle of least harm, very important. Quality of life. Do we want to limit? We might need to limit certain things, but we may not have to limit everything. But a person can still have a quality of life. Privacy and confidentiality. Truthfulness and full disclosure. We want to be honest with our families and patients. In this case, maybe a lot with our families. We can be honest with our patients too. That doesn't guarantee that they're going to remember the next time we see them. But really work with families. Y'all ready for a little bit of cultural competence? Sure. I know. What does it mean? Yeah. I don't know, I got a big yawn over here. All right, okay, we'll continue, and remember, we're done at 4. Don't believe me, I'll keep talking. Okay, cultural competence is a process by which individuals and systems respond respectfully and effectively to people of all cultures, languages, classes, races, ethnic backgrounds, religions, and other diversity factors, including but not limited to gender identity expression, sexual orientation, and marital or partnership status, in a manner that recognizes, affirms, and values the worth of individuals, families, and communities, and protects, preserves the dignity of each. That's a really, not a long definition, there's a lot in there. Okay? There is a lot to cultural competence. It's a big point. Now, here's your good take home. It's also a practical and concrete demonstration of ethical principles of respect for persons, beneficence, doing good, non-malfeasance, not doing harm, we talked about that earlier, and justice, treating people fairly. These are the more important things that we need to remember about our ethics when we're dealing with any patient, particularly when they're going to be when they're in other cultures. Okay, these are the cornerstones of modern ethical codes for health professionals. These are the ones. These are the things that we have to keep in mind. It's in being able to treat our clients. We want to keep these in mind as we're understanding as much as we can about them. Now, NASW has a couple of codes of ethics that deal with cultural competence. The first one is social workers should have a knowledge base of their clients' cultures and be able to demonstrate competence in the provision of services that are sensitive to clients' cultures and to differences among people and cultural groups. And the second one says that social workers should obtain education about and seek to understand the nature of social diversity and oppression with respect to race, ethnicity, national origin, color, sex, sexual orientation, gender identity or expression, age, marriage status, political belief, religion, immigration status, and mental or physical disability. I believe that covered everything. But it is and I don't think that, I'm sure that other health professions share similar values, share similar codes of ethics. Okay? So it's important to learn about other cultures. Now, when we look at diversity, a definition for diversity is looking at individual differences on a number of variables that place clients at risk for discrimination based on age, gender identity, race, ethnicity, cultural and national origin, religion, sexual orientation, disability, language, or socioeconomic status. There's a lot of commonalities to all these definitions. And we'll get to this. Some values and assumptions that are important to keep in mind is counselors who operate from culturally biased views of mental health and who use interventions that are not congruent with the values of culturally diverse people perpetuate forms of injustice and institutional racism. And another assumption is that ethnocentric bias has been destructive to natural help-giving networks of minority communities and with a failure to incorporate diversity factors into practice play, and this is infringing on a client's cultural autonomy. Now, in years and years ago, in research that was related to patients and practitioner interactions, there was a problem with the patient. The reason the patient wasn't getting better is because they wouldn't do what the practitioner told them to do. What wasn't looked at is, did the patient understand everything that the practitioner was asking them to do? So for a good while, the patient was the one at fault. Well, over the years, that has changed to be able to look at more, it's the practitioner that's actually more at fault for not understanding everything about the patient and not delivering their message in communicating what they need to communicate to the patient. If you're talking to a patient but they don't understand you, yes, you're saying what you're supposed to say, but is that more important, or is it more important for the patient to understand what you want them to do to get better? What would you guys think? We want them to understand what we would like them to do, or do we just want to make sure we sound good and professional? I would think so too. And again, that's something that years ago it was more of a client deficit. Now it's really more of a practitioner deficit, and that's where we have one presentation like mine, along with lots of other presentations that are about cultural competence and delivering services and also understanding patients and really learning more about different cultures. And what we don't want, one of the things is hopefully you're taking in things that I'm talking about, that you would be able to do this with any client of any culture, okay? It would be really important to be able to do that. You might get an Asian person come into your office, and, well, what do we do? Well, we would want to learn about their culture. We can learn from them also about their culture. So now, some biases are reflected when there's neglect of social and community factors to focus unduly on individualism. Assessing clients with instruments that have not been normed on the population that they represent. Last month, we talked in McAllen, and there were different people there were other providers that were outside, and one that I had met a while back that does caregiving groups to teach caregivers how to take care of themselves. So she asked me, well, what can I do to improve the numbers? Well, one of the things she told me is that their program that they have, that they offer, comes from Stanford University. Well, what do we know about Stanford University? Sounds like a really good program, right? Well, it's a really good school, very smart school. So it should be a really good program. Okay, well, that's good. Well, then I said, well, is it translated? Well, no, they let us translate it. So then I said, is it back translated? Then what do you mean? Well, what back translation is, here's what back translation is. If I have an instrument in English, and I give it to one of y'all to translate from English to Spanish, then I'm going to take that instrument and give it to another person to translate it from Spanish to English, to then compare them. So that hopefully they mean everything we want them to mean. Like I mentioned earlier, I have concepts that might be in my English version. And I want to make sure that those concepts are also in the Spanish form. So I can't just literally translate. I need to make sure I use the correct words and the correct phrases. And a lot of it might even be regional. Because there might be a language in Laredo that might be much different or a little bit different than what is spoken in the Valley. And that might be different than what's spoken in Corpus Christi. Okay, and everybody's right, but as a person that's doing the work, I want to make sure that they understand what I want them to understand. So that's what this one bias is about, is making sure that just because I have a scale that has all these great things about it in English, doesn't guarantee it's going to translate well and do well in Spanish. So hopefully then I can find something that has also been tested. And some of the newer scales and instruments are actually doing that. So because that's important to have anyway. Judging psychopathology or pathological behaviors, beliefs, or experiences as normal for the client culture. Oh, well, that's okay. That's how they are. And the last one here says, strictly adhering to Western counseling theories or Western education without considering its applicability to the client's diverse cultural background. And a lot of this has to do, again, with meaning. One thing that, and this goes back to that practitioner model, explanatory model, for understanding, say, in this case, mental illness, or even experiencing dementia and Alzheimer's, and how the clients experience it. I can easily look at all the books and all I've learned, but does that mean that the client's going to understand it the same way? No. Yeah, as a professional, I might say, well, the person's in stage 3 of Alzheimer's. And what's the family thinking? Mom or dad's starting to forget again. But I'm going to leave it alone, because maybe they just had a bad day. They're fine. We need to keep that in mind. So again, going back to the Western versus Eastern, the degree to which Western values and orientations fit clients from Eastern or other cultures needs to be carefully considered. You need to really understand that client's culture, that client's beliefs. And then back to the climate stuff, we want to understand their explanatory model. How do they explain it? How do they experience it? Now, some common assumptions that we have to be aware of is self-disclosure. In some cultures, self-disclosure is unacceptable, so you don't talk about things. So it's not that maybe they don't trust you, but we're just, I'm fine. Nothing wrong with it. Even though the doctor might see something, or even the families, they're saying something, nothing wrong with it. Or again, at the same time, that might be part of what the family's going through also. Now, directness and respect in some cultures might be perceived as rude or something to avoid. So it's on us to make sure that we're communicating with clients, and particularly when clients don't respond. We want to just make sure that we're careful with that. And then also recognizing our own nonverbal behavior, but their nonverbal behavior. Respecting personal space, respecting eye contact, handshaking, any formalities, okay? What happens if you have an interview with, let's say, an older Mexican American female, and she was really happy that you talked with her? How do you say goodbye? Do you say goodbye and I give you a handshake? Maybe. But what might they do? They might want to hug you. So if you say no to the hug, so again, I want to, I would respect that. Not that you give a full hug, but again, okay, you would, so that then when you come back the next time, there's still an open door and they're still going to talk to you. Otherwise, again, you might be setting a limit that you need to be set. Okay. So now, with our service delivery, within our agencies, hopefully we're going to, one, recognize we are cultural beings, that we hold attitudes and beliefs that can influence our perceptions and interactions with individuals who are ethnically and racially different than us. We need to recognize that the importance of multicultural sensitivity and responsiveness, the knowledge of or understanding about ethnic and racial different individuals. We need to know, we need to make sure of that. For those that maybe grew up in Laredo and might be working with, say, let's say older adults, what happens if you have an older adult that's Mexican American, but for whatever reason they moved from California? Are they going to be the same as an older adult from Laredo? Possibly not. So that's why we want to make sure that we recognize that. Okay. We want to employ multicultural and diversity in our practice, always. We want to make sure that we're open to everything. Again, for professionals, we want to apply appropriate skills in our clinical and other applied practices. And as an organization, we want to use organizational processes to support culturally informed organizational policy development. It's important that not just us as individuals are doing things that are culturally competent and diverse, but that as an organization that's respected. That's all part of the program. Now, I read some research years ago about organizational change and organizational, not necessarily change, just policy, and particularly with where services were located. And this research that I read was about a program like in the Northeast, but that had a significant Hispanic population. So to get the Hispanics to go to treatment, instead of the senior center that they had that offered integrated services, which mean integrated services mean that a lot of things were there, not just a senior center, but then they could have other things checked and instead of having to go all over the place. They even offered mental health services, but Hispanics would go, and some people wouldn't go. So they found another place not too far away that was a house that they turned into an outpatient clinic. So they made it look more like a home than a clinic, and that helped out a lot of the patients. So that's another part of service delivery, of doing that kind of organizational change. A lot of times nowadays, you might see certain social service agencies that are more in houses than in those nice buildings that have the bright lights, and you have to go through who knows how many elevators or doors just to get to one office, just to get to the secretary. Oh, look, last slide. Now we're thinking, is he done yet? Actually, we have some time for some questions or comments. Please talk to me if you have any questions. I'll give you an answer. It may be a good answer. Tell me what do you guys think? Where did I miss? You can always improve things, by the way. Family members, what are your thoughts?
The healthcare professionals, I mean, the last time that my mom was in hospital, we had a case manager that talked to my sister about my mom's condition and about all the services available. Although she spoke in English and my mom doesn't understand English, when I found out about it, I was upset because my mom kind of hung on to every other word. So every time she got out of the hospital, she's like, well, what are you going to go here? Or what about this? So I called the hospital and I told them my concern that I didn't want anyone to come to my mom in front of, to my family in front of my mom But I felt like, isn't that something that the healthcare professionals are supposed to know? Like, I mean, they have the files, you know, my mother's already diagnosed with Alzheimer's, with dementia and Alzheimer's, and they should know certain things. Although I know, like my sister, I guess she didn't think of it at the time, but let me step outside and talk to you.
Is that, yeah.
I think as healthcare professionals, there should be a little bit more training in sensitivity in that. It's just like, the same thing goes for when my sister comes from out of town and the home health nurse goes to visit my mom. I know my sister got upset because the nurse was asking the caregiver more of the questions than my mom. And we're like, well, yeah, but the correct answer she's going to give from the caregiver, not from my mom.
Right.
And my sister was having a hard time understanding that.
Yeah.
So,
Well, the first part of what you talked about with as professionals, it's really important to read the chart, to learn what is the diagnosis, and in particular in this case, what is language of preference also, and to also understand that maybe this needs to happen in private. Now, as family members, it's something that you basically said this already, is that maybe the next time that were to happen, that you say, hey, can we stop outside? That way it's easier, because like you said, your mom's going to hear all this stuff. You know, well, what are we doing all this? And say, well, you know, and then they might know that for the day, and then they may be gone possibly, depending on where they're at. But still, that it creates some stress for the caregiver. Now as far as for the caregivers, and you family too. Now, as far as like the primary caregiver and a nurse, that's also important to learn, to know, and to teach your sister that when she visits that's the better thing to do, because that caregiver may know your parent more than you because they might spend more time. It doesn't mean that you're not spending time and you don't care, but to get the best information to the professionals, we need to go to the best sources, correct? You know, I know with my wife, her mom's like somewhere in the middle stages, possibly even a little bit further, with Alzheimer's herself, and has a caregiver, and the caregiver goes to the doctor. And of course, I get tapes. We schedule on Mondays, because that's the best day I can go. But we go, and now what I'll do is go back for the visits with her doctor, although she's going to be the lead. And all I'll do is represent my wife and her sister to ask any other questions. So that way there's all the information, all the questions that we want to ask the doctor, so that we can give, they can make the best decisions based on all the evidence that they need and all the information. And at the same time, we're now taken care of because the questions were answered. And you kind of said that. Other thoughts? You know that's one on Facebook, right? Or YouTube, right? You do not finish. Other questions or thoughts about what we talked about? Or what I talked about? Somebody else.
I remember one time when my dad was in the hospital. We were very fortunate to have real good caregivers. And the one caregiver, whenever we went to the hospital, they followed us to the hospital. They weren't at the hospital with my dad. And one of the caregivers had been with my dad already for like 5 years. So she knew my father like the back of her hand, right? And the nurse walked in, an RN, and kind of looked at her like, well, who are you? And I turned to the nurse and I said, this is the lady that's been taking care of my dad for 5 years now and that knows him better than, probably anybody. So you treat her with the respect that she deserves, because she does know my dad a lot better than you do, probably better than myself as far as he needs, because she takes care of him on a day-to-day basis. So there has to be that respect for people that take care of the patient, because they do know them better than anybody else, because they're with them all the time. So yeah, to me that's important.
Yeah, and you, the hope would be as professionals, when we're going out and either they come to our office or we go to them, that in our assessment, because we're always assessing, okay, in any of the helping professions, to help our client get better, or at least have a better quality of life, we need to make sure we're getting the best information from the right people. You know, my mother-in-law loves to go into the doctor's office and just put on a show. Laughing and joking, and I think that's getting hard for her to do. But she also knows that she has an illness, and she has an idea of what it is. And at the same time, though, she, was a lady that grew up in Heberville, Texas, and not from a very rich family, and all did the work and all that stuff. And was very, her and her husband were very successful in corporate after they moved over there. And built a really good, raised great children, all that stuff. And, so she's a very strong person, and she would throw people out of her convenience stores. Okay. But again, to understand all that about your client.
Okay, thank you. The second floor, second floor. Thank you.
I'm going to believe this.
Okay, okay.
That's okay. I'm sure it was important.
Yes.
Yeah, no, okay. Here's the funny part. When I did this similar presentation last month, the same thing happened. Somebody needed to take a call, and it was very important. I'm like, really? I mean, it was very important. So.
It's my supervisor, a religious sister from Ursuline.
Okay.
See, I attend a Catholic Social Services Senior Center.
Okay.
I'm a member there.
Okay.
So I skipped the banquet for Mother's Day in order to come and attend this workshop.
Oh, man.
So they were kind of upset with me for choosing to come to spend my day here with this workshop. And I'm
Really?
being among my other senior
Right.
members.
Okay.
But she's coming to give me a gift. So
Oh,
I'm
good.
just going to step aside now.
Well, I'm going to have to tell her she needed to be here today. Okay, yeah, great. But y'all want us to have that celebration on Monday for you. That way you can share everything you've learned today with your fellow community members. And this is all important stuff. Don't get mad at me.
And let me mention, it's very hard to adjust to being a senior myself. See, I started working as training to become a licensed vocational nurse when I was 17. And I worked at Old Mercy and LMC for 45 years. But the great blessing that I always tell any person, I have grown and I have aged and I have seen my children grow, be independent, I've seen grandchildren, and now I'm being blessed. I have 2 great-grandchildren. And that's a great blessing to me, and that's my joy of being a senior right now. Excuse me.
No, not a problem. That's awesome. I know my mom spent some time at her own senior center, and she didn't go like, there are senior centers in certain areas or cities, but she didn't go to the one that was like close. She went to one in the rural neighborhood. And it was the members that were there at the time were people that she grew up with. So she had a great time there. And it was better, even though it was a little bit more of a drive for her, it was better for her to go there. Well, I believe we're right on time. But I would encourage you to share any of our information that you learned today with other people. That's really, really important. Thank you very much.
Thank you.
Dr. Gonzalez, thank you so much for all you've done, and thank you so much for appearing for us and speaking to us. We really appreciate it. As a token, a small token, so here is a plaque with a painting created by an individual who has Alzheimer's. So I'd like to give that to you as a small token of appreciation for the things that you have done for us and for the education you have is submitted for our community. Thank you very much. Okay, before I conclude the conference, I will end where I started, the paperwork. Remember to complete your conference evaluation, front and back. To complete your participant profile form. Remember, this provides future conferences to be held at various locations in Texas at a low cost or free as far as this is. So you can please pass the paper forward and complete your profile so we can provide future conferences for other communities around Texas. For those who are seeking continuing education credits, be sure to complete your statement of attendance. It's going to be the second page. Go ahead and just tear that off and complete it in its entirety to make sure that you receive the credit that is due to you because, well, you paid for it. And lastly, your symposium data DVDs. If you're wishing to receive some DVDs from us, remember it is free. So be sure that you fill out the form completely and to request a certain amount of CD discs that you want. And please give us grace and give us some time to process, to create and distribute CDs to you for your purposes, and so you can definitely pass the word and educate others what you learn here. I'd like to thank very much the University of Texas Health Science Center here in Laredo. Definitely Julie Bazan for everything she has provided. And just thank you so much for attending, for coming out here and taking your Friday off and attending this wonderful conference. And we have been very happy to have you attend. Just thank you so much for all you've done. Everybody please have a safe, wonderful trip back and have a great day and a good weekend. Thank you.
Up in white linen, I see by your outfit that you are. These words he did say as I boldly stepped by. Come sit down beside me and hear my sad story. Shot in the breast and I know it was once in the saddle I used to go a-dashing. It was once in the saddle I used to go gay. First to the drum house and then to the cart house. Got shot in the breast and